Welcome back to Cycle Wisdom, where we empower women to restore natural menstrual cycles to improve health and promote fertility. I'm your host, Dr. Monica Minger, and I'm so glad you are listening today. On today's episode, you will hear the second part of my interview with a dear colleague of mine, Dr. Sadaf Lodhi. We're going to continue to talk about how estrogen levels change as women go through perimenopause and into menopause. We will talk about the importance of estrogen on brain health, and most importantly, we will discuss ways to treat this estrogen deficiency and the safety of being on hormone replacement therapy longer term to help prevent troublesome symptoms and chronic health problems. I hope you enjoy this follow-up episode as much as the first. So I know you had mentioned that for utilizing the vaginal estrogen, that women can stay on that for life. What about as far as for like the pill or the patch? How long do you typically recommend people stay on those, since those are more of those menopausal symptoms, the hot flashes?
Yeah. So, it's interesting that you asked that, because there was a study that came out, and it really needs to be individualized to the patient, see what their needs are. But before, we used to think, okay, and this is something that we heard all the time as residents. In fact, in residency, we didn't even learn much about menopause because of the WHI study that came out, and physicians were not prescribing hormones anymore. But, we used to hear that, if your patient is wanting to go on estrogen, then you do the least amount for the shortest amount of time, which is actually not the case. So there was a study that was published in the Menopause Journal about the use of menopausal hormone therapy beyond the age of 65 years and its effect on women's health outcomes by types, routes, and doses. So the study looked at the use of menopausal hormonal therapy beyond the age of 65 and its health implications by the types of estrogen, progesterone, the routes of administration, and the dose strengths. What they found was that compared with never use or discontinuation of menopausal hormone therapy after the age of 65, the use of estrogen by itself after the age of 65 was associated with a risk reduction. So if you're using estrogen, and compared to those women that never use estrogen, those women that did use estrogen, they noted a decreased risk of mortality from breast cancer, lung cancer, colorectal cancer, congestive heart failure, blood clots, atrial fibrillation, acute heart attacks, and dementia. It's a lot of stuff. Yeah. So that's all for women that used estrogen compared to women that had never used estrogen. If they discontinued after the age of 65, or if they never used estrogen, compared to the women that took the estrogen and they continued to take estrogen after the age of 65.
So a good reason to say, hey, it's okay to continue it past 65,
Exactly. And that's really what it boils down to, is that, of course, all of these discussions have to be individualized, and you have to look at the risk versus the benefit. And is the patient really achieving the benefit that they're supposed to achieve? But if they are, and if they're doing well, then there's really no set age limit to how long you can keep that woman on estrogen, and that there's benefit, what they noted after the age of 65, which a lot of times, women will be taken off of their estrogen, and they're saying no, that there's still a benefit to women that have been on estrogen, that continue to take estrogen after the age of 65. There's still benefit that we see. The takeaway here is that menopausal hormone therapy after the age of 65 years vary by types, routes, and strengths, right? So we know that there's pills, there's the spray, there's the estrogen gel, or the patch. And so there's different types and routes and strengths. And we know in general, risk reduction appears to be greater with low rather than medium or high doses, vaginal or transdermal rather than oral preparation. So we're talking about, the patches tend to be a little bit better. And of course, there's the vaginal estrogen ring. We know that there's systemic estrogen that you can get via ring as well. And so they say that those tend to be more beneficial than the oral estrogens, and that estradiol is better because estradiol is the one that we consider the quote unquote bioidentical, as opposed to, let's say, the synthetic equine estrogens that were used in the WHI study. So there's different types of estrogen as well. So the ones that we know that tend to be the safest is the estradiol.
So that actually made me think of just another question. Are there ever indications where you would have somebody on both like an oral or a transdermal estrogen and also be doing the vaginal estrogen? Or is it basically if I'm covering with something systemic, I don't need the vaginal estrogen?
No, so I do because, sometimes I feel like they don't really get all of the benefit in the vagina or the vulva. So I actually do both. So when I'm prescribing it for a patient that is a candidate for menopausal hormonal therapy, what I do is I tend to almost always do the estradiol patch. And if they have a uterus, I'll do the progesterone because, one thing I want to remind your listeners is that if you are taking estrogen and if you still have a uterus, it's very, very important that you also take progesterone because estrogen by itself can cause an overgrowth of the lining of the uterus that can lead to endometrial cancer, the uterine cancer. So you want to make sure you don't do that, right? So you always, if you still have a uterus, you want to make sure you're always taking progesterone with that. It may be the progesterone pill orally, or you can do the progesterone vaginally, but really it's progesterone that you need to be taking along with the estrogen if you still have a uterus. And I do the vaginal estradiol cream along with the systemic transdermal patch. So along with the patch, I will do a cream because I feel like it doesn't always reach there and there's really no harm in doing the vaginal estrogen. So I will always do the vaginal estrogen, always, just because I feel like it gets in more to the tissue that it needs to go to of the vulva and the vagina. And it's going to prevent my patients from getting recurrent UTIs, prevent that overactive bladder. Remember, there's estrogen receptors in the vagina and in the vulva that need that estrogen. So I just go ahead. I always do the vaginal estrogen cream along with if I'm doing systemic. So they no longer state, and I don't even know if they ever stated that or if that was just something that practitioners said and that just was something that we heard and we carried on forever. But really now it's just, it's patient-centered. And you have to just talk to the patients. You have to tell them the benefit, the risk. The most benefits that we see is when a woman goes on hormones, really in perimenopause and early menopause. And the North American Menopause Society, their recommendation is within 10 years of menopause or less than the age of 60 is the best time to begin hormones. And in terms of when do you stop, there's really no end date now anymore.
So what about, I know there's been a lot of studies too talking about the links between estrogen and dementia or brain fog or memory loss. So how does estrogen affect your brain and really your emotions and the other things that are processed from the brain standpoint?
So, estradiol, it plays a huge role in anxiety and depression. And, oftentimes the question that comes up is what is causing those mood swings? And what we've learned is that because the estrogen levels, they fluctuate during the reproductive cycle. So we know that, even women that are menstruating, right? There's a time when they're in PMS, right? They're having those mood swings and that emotional lability, and maybe they're, lashing out at their partner, or their kids or whatever, because it's right about their period time. We noted that, of course, during perimenopause, we definitely get those fluctuations in estrogen. And what happens is that these increase in the fluctuation of the estrogen can even result in new onset depression. So even women that never had anxiety or depression, they can note that they start to get depressed. And the reason why that is due to the fact that there's so many estrogen receptors in our brain, and they're located in the amygdala, in the hippocampus, and the hypothalamus. And so when we don't get the estrogen to those receptors in that part of our brain, it can result in brain fog. We also know that the hippocampus is responsible for memory, learning, and emotion, and it holds the short-term memories. So when we don't have, again, that estrogen, that can result in brain fog. And also the hippocampus, when we have that estrogen, it results in putting those short-term memories and transfer them to a long-term storage in our brains. And so when we don't have the estrogen, then that's why we can become forgetful and be like, oh gosh, I was about to say something, or, I know I was going to the kitchen for something, but I can't remember why that was. And that's why that happens. The estrogen is what's helping with emotional processing, including anxiety, and the amygdala helps process emotions. So it's also linked to emotions, to memories, learning, and our senses. And the hypothalamus also helps to manage our body temperature. So that's why we get the hot flashes and the night sweats and all of that, because basically that's also being affected by the estrogen. And there's these things called candy receptors in our brain that is where that medication is for those that are not able to take estrogen, that can help with the hot flashes and night sweats. And the hypothalamus also, like I said, helps to manage the body temperature, hunger, thirst, mood, sex drive, blood pressure, and sleep. So that's why a lot of times, women can experience the new onset anxiety, the new onset depression, because the estrogen receptors in our brain are not getting the estrogen that it needs. And so we have that mood lability.
So are there things that we can do to help prevent that significant shift? Or is it basically just the answer is everybody needs to take estrogen? I mean, are there other things from a lifestyle standpoint or supplements or, lifestyle choices that we can make prior to getting to menopause that will help to ease that transition? Or is it basically just everybody needs to be on estrogen once they get to that point?
So there is a physician that has done a lot of research in neurology and the brain and menopause. Her name is Dr. Mosconi. She's done tons of research and work on that. So I'm going to ask people to follow her. But I think that, definitely we know that estrogen plays such a significant factor. So if you were ever considered or on the fence about whether or not you should take estrogen, I think that unless you have contraindications, which may be like active liver disease, and that, of course, that's for oral cancer that's estrogen receptor positive, and actively being treated for cancer, or you have unexplained vaginal bleeding, any of those things, obviously you want to have all of those things addressed before you go on estrogen, but, definitely consider estrogen. I think that just going on estrogen itself is really, really important and does help with all of those things. So you wanted to know, are there other things that people can do? Well, for osteoporosis and to prevent that, because we know if we don't go on estrogen, then definitely that's going to affect our bone density and our bone mass. And so for that, I would say increase weight-bearing exercises. I think that's really important. I think increasing the amount of protein that you intake is really important. I think also increasing your fiber intake is also very important for women as they go through these changes. And we know, and studies have shown, that just going outside is very important for our mental health. I've seen multiple times where, the key to longevity is going outside, eating protein, increase weights, and sleep. And those are 4 things that everyone needs to increase longevity as we get older.
Yeah. And regardless of where we're at on that spectrum of having cycles or not, I think those things are all important for all of us.
Yes, absolutely. I think it's really important.
So tell our listeners a little bit more as far as where they can find you, how they could work with you. What does that look like?
Yeah. So if you're in New York, I'd love to see you as a patient. I'm opening up my sexual health and menopause office in Westchester County, New York. I also do telemedicine for New York and also for Michigan. But outside of that, I'm also an intimacy coach. So I talk a lot about the way people feel and if they are stuck in their relationships, how they can move forward in their relationships being a coach. And for coaching, actually, I can work nationally or internationally, and that's not subjective to state lines or anything like that. Also, I have a podcast called the Muslim Sex Podcast. I'm also hosting a retreat September 16th through the 23rd of this year. It's going to be in Morocco, and it's with another gynecologist, and we're going to be talking about nutrition. She was a dietitian before she became a gynecologist. So we're going to be talking about nutrition and menopause and sexual health, and it's really how to nurture and nourish your mind, body, and soul. So I'm really excited about that one. I'm on social media, of course. I'm at Dr. Sadaf OBGYN on Instagram and on TikTok, and also Dr. Sadaf on Facebook and Dr. Sadaf Intimacy Coach on YouTube.
Love that. And we'll make sure that we post all of your social media handles in our show notes. So that way, if you want to get in touch, depending upon where you are and what needs you have, Dr. Sadaf is obviously very, very knowledgeable when it comes to women's health across the spectrum. And so she would be fantastic to work with. So thank you so much for spending some time with us today, for educating our listeners, for educating me, and for helping us to get the word out about the importance of watching what's happening with our hormones throughout that entire transition timeframe.
Thank you. Thank you for having me on.
Imagine if you were able to have a conversation with a doctor who is knowledgeable about the hormone changes you experience as you go through perimenopause and navigate the switch that happens when menopause occurs. Imagine how that could change the trajectory of your health, your symptoms, and your quality of life when you are in your 80s or 90s. This way forward is possible through working with doctors like Dr. Sadaf Lodhi, myself, and others to improve your health for years to come. If you're ready to work with our elite team of healthcare professionals, go to our website, radiantclinic.com, to schedule a free discovery call with me and learn more about our package-based pricing for comprehensive care. We are currently able to see people for in-person appointments in the Cedar Rapids, Iowa area, or can arrange for a telehealth visit if you live in the state of Iowa or Illinois. Thank you so much for listening to this episode. Please share this podcast with someone in your life who would benefit from our services. Remember to subscribe to this podcast for more empowering content that I look forward to sharing with you on our next episode of Cycle Wisdom.